Welcome to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group and Faculty Associate at the Arizona State University College of Health Solutions. Here we explore the vast and rapidly evolving healthcare ecosystem with leaders across the spectrum of healthcare delivery. Our goal is to promote ideas that advance the quadruple aim, including improving the patient experience, improving the health of populations, lowering the cost of care, and attaining joy in work. Please send your questions, comments, or ideas for Healthcare Rounds to podcast@darwinresearch.com. And if you like what you hear, please don't forget to rate and review us wherever you get your podcasts. Let's get started.
Today, John speaks with Dr. Thomas Hale, CMO of VirtuSense Technologies, a healthcare company that is using proprietary technology and artificial intelligence to reduce adverse events within hospitals, skilled nursing facilities, and senior living communities. Dr. Hale previously worked as Senior Vice President for Care Solutions at Navvis Healthcare after a 37-year career at Mercy Health, where he was the leader and clinical architect of the world's first virtual care center. As Executive Medical Director of Mercy Virtual, Dr. Hale led the development of new ways to effectively and efficiently deliver healthcare to Mercy communities. Prior to being named to his current position, Dr. Hale maintained a general internal medicine practice for 23 years. He was a founder of Mercy Medical Group and served as its first president for 15 years. Dr. Hale holds a PhD in pharmacology from St. Louis University. He received his medical degree from the University of Missouri-Columbia Medical School, subsequently completing his internal medicine internship and residency at Mercy Hospital St. Louis, leading to board certification in 1983. In 2011, he earned a master's degree in medical informatics from Northwestern University.
So, Tom, to orient your listeners, tell us a little bit about your background. And first, I want to say thank you up front for taking the time to speak with me. By the magic of podcasting, we will have already read in kind of a stiff bio for you, but maybe in your words, where you've been and where you are now.
Yeah, no, I appreciate that, John, and knowing that the bio has already been presented, let me just tell you some highlights. So after I got a PhD in pharmacology, I went on to medical school and then became board certified in internal medicine, started a practice, general internal medicine, and realized really quickly that it would be difficult to get some of the things done that I wanted to do for my patients unless we were much better organized. So we partnered with a group of physicians, partnered with Mercy Health, and we started Mercy Medical Group, of which I was the president for 15 years and one of the original founders. And at the time that I moved on to other things, it was about 375 physicians in total, 200 primary care and about 175 specialists. From there, I was asked to be the lead physician for our Epic implementation, which at that point in time, I think I was blamed for divorces and illnesses and all sorts of other things as we moved to electronic medical record. And that became my first actual understanding of what real change actually meant, particularly with technology.
Sure.
Following that implementation, which was through 44 hospitals and about 2,000 physicians, the CEO of Mercy asked me to start an innovative care center, which then became evident to us, evolved into what we labeled as virtual care. It was more than just telemedicine. It was all the rest of the things that supported telemedicine, which was the technology, the data, but also the preservation of relationships. And it was at that time we established the world's first virtual care center, which I was the clinical architect for in St. Louis, Missouri. And then I retired from Mercy at that point in time, where I was the executive medical director of the virtual care center for about 5 years.
Okay. And we're going to get to your new company, but I wanted to talk a little bit about the virtual care and the time that you spent sort of as a precursor to the big building. I think a lot of our listeners will know that center is one of a kind, and is one of the largest, if not the largest in the world, right, at this point, in terms of services offered, number of visits, certainly top 5. So I wanted you to kind of talk a little bit about some of the early lessons that you learned, some of the key wins with this application of this technology. And what were your observations?
Yeah, no, I appreciate that. We actually started at Mercy before we evolved into the virtual care center type of thinking. We started with the EICU, and I would recommend to anybody that that's never where you should start. It's one of the most difficult processes, even though it's highly developed at this point in time. But it also is the less economic rewarding, and it impacts actually the fewest of patients that you can impact. But it is very important. We started with the EICU, and one of the first things that I learned actually, which was interesting, because we started with one-way video. We had video into the room, and then we had audio with the nurses at that point in time. And then we would make recommendations, because as we observed the patient 24/7, we had all their data feeds coming in, and we'd make recommendations. Our compliance was actually very low between our recommendations and what the nurses actually ended up doing. About 6 to 9 months into it, we moved to two-way video, and now they could see us at the other end. And interestingly, their compliance went up 60%.
Wow.
And what I gathered from that was that now all of a sudden we had a relationship. That video feed, that video picture, just like a Zoom meeting or a lot of things that we've done with telemedicine recently since the pandemic, it is now viewed as a relationship. And we did carry that through with some of the other things we did. The second project that we went to, so we gathered all this data from the EICU, and it was remarkable 24/7 information that we could get and apply algorithms to that. And so we decided to do a project on sepsis in the hospital. And so and this is where we came through with what we've labeled as the virtual care paradigm, or the telemedicine paradigm. We took our patients as they entered the hospital, and we took those that were at the highest risk for developing sepsis. It was about 20% of the patients that were admitted. And then we monitored those patients 24/7 as best we could, because we did not have a lot of continuous monitoring necessarily on some of the acute floors, which gets to something we'll talk about later in our evolution. But and then we took that information and we took it to a centralized repository, of which a nurse could actually cover 1,000 beds, because of the computer artificial intelligence that was behind it, supporting her. And when someone's vital signs became as changed, and it looked as though we were beginning to develop sepsis, initially we called the doctor. And I'm a physician, so I don't take this personally, but that was a disaster. Because we called the doctor, and that's where we added a lot of variation, because half the doctors would say, great, follow through, and the other half would say, I just saw the patient tonight, we'll wait till the morning. And as most people understand, that by the morning in sepsis, you might be dead, or certainly you've evolved into a much more serious condition. And so we took that out of the workflow. And so the paradigm was you segregate your patients as you're testing, you centralize the information in a central location, and then you send the alerts to those that can act at the bedside. And it was remarkable what happened, because it took the variation out of the care. This was the other aspect that we learned as we developed, that you have to get rid of variation. And I guess the best example was that we decreased the evolution of severe sepsis to septic shock by 90%. And we actually decreased both our results in mortality and morbidity on sepsis, severe sepsis, and septic shock by some 40%. So it really was fun. Our best results were in the emergency room and the ICU. The least best results were on the acute floor, and that was all about the whole monitoring situation.
So when you say that you remove the doctor, is it so as a physician is monitoring this, or was it the nurses, or in other words, how are you able to remove that part of the equation and eliminate the variation?
Yeah, so remember, we centralized all the data to one area, to one nurse who was being supported by the computer. And the nurse at that time sent the alert to the rapid response team. In the initial part, we sent the alert to the doctor, and the doctor either sent it to the rapid response team or didn't. Instead, we sent it directly to the rapid response team, who went to the bedside, reassessed that patient, and if they met all the criteria that was agreed upon by the physicians ahead of time, then they administered the sepsis bundles to that patient. And so what we decreased was actually the variation of sending the alert to the nurse directly rather than having it screened by a central location with AI. And then secondly, taking the doctor out of the decision-making process because he or she could not be at the bedside, like the rapid response team.
Makes sense. So, and then you said where you performed worse was in the general floor?
Yeah, so this was another learning and actually has set me to where I am today, because on a general floor, we weren't monitoring the vital signs on a continuous basis like we were doing in the ICU and in the emergency room. And so we may have only gotten 4 or 5 data points. We still had a better impact because of the decrease in the variation, but we needed more data. And we asked Philips, interestingly, at that time, and maybe I shouldn't say the companies, but and they said, sure, we can virtualize your room for monitoring. It'll cost you $60,000 a room. Well, that didn't fly. And it isn't until recently now that and we'll talk about this later in the talk, but where we have a wearable technology that is as good as what I was using in the ICU back in my days, that can then sample that data 128 times during the day, 24/7, with unobtrusive to the patient, including oxygen saturation, blood pressure, pulse, temperature, core body temperature, all sorts of things. And now I can't wait to restart that whole sepsis algorithm again, because now we'll have data points that will be able to impact a great number of more people as though they were all in the ICU.
So now let's get to why I'm excited to talk to you and how we were kind of pulled together. And that's your latest venture where you're Chief Medical Officer with VirtuSense. This technology is amazing. I couldn't believe it when we were talking about this just last week. So maybe talk a little bit about the technology, and then how does AI predict when a medical event is about to happen, or when some event like a fall?
Yeah, no, I appreciate that. So VirtuSense, I was very fortunate after I retired from Mercy to get hooked up with VirtuSense. It was shortly after I retired, and VirtuSense is a company that is not a technology company; it's an artificial intelligence company. And what they do in general is take information from sensors, and then that gets into their machine learning artificial intelligence engine and algorithms that then can take that data and say, okay, this is an alert. We are about to have an event. What they started with was fall prevention, and they used LiDAR technology, the infrared technology that one sees in autonomous automobiles. It sends out, we send out 22 some odd RF sensors out onto the patient's body. And after millions and millions of hours of monitoring patients to build that algorithm, as the artificial intelligence engine began to discern the difference between someone sitting up and someone making an attempt to get out of bed or get out of a chair. An example would be able to tell the difference between the patient and a curtain, which may move like a person if a breeze comes through, or the ability to be able to tell someone is 2 feet from the bed and therefore assisting that patient instead of that patient getting out of bed on their own. And what ended up happening was the creation of something I never saw. And I think we've seen this, by the way, with the advent of the vaccines in such a rapid period of time using artificial intelligence and computer technology. The development of a highly sensitive, meaning that this picks up the patient beginning to exit to the exit of the bed or the chair, and highly specific, meaning that the false alerts of what's happening to that patient is less than 1 in a 24-hour period. And so what ends up happening is we can tell when the patient's getting out of bed, even before they physically feel that they're getting out of bed and give the nurses 60 seconds, an alert with 60 seconds of anticipatory time to go to the room. And instead of greeting them on the floor, which is what happens today, they greet them at the bedside before they exit the bed, or at the chair side before they exit the chair.
That is amazing. Like, how
That's
does
cool
it,
stuff.
it's like, how does
how
it
do it do that?
how do it do that? How does it know or anticipate? Like, I get it of a movement sensor, but is it just, based on thousands of patient encounters, the AI knows that, okay, this patient within the next 60 seconds or so is going to attempt to get out of bed, and they shouldn't be on their own. Is that kind of how it works?
Yeah. But it has to start somewhere. So it starts with one patient, and it's wrong as often as it's right. And then it corrects itself. So, okay, what I thought was getting out of bed wasn't, or what I thought wasn't getting out of the bed was. And so it continues to correct itself with machine learning, and the algorithms begin to develop for the AI. So on millions of hours of monitoring patients, it continues to get better. Our first effort, when it came out, there were probably 3 false alarms because we mistook getting up to eat. We mistook somebody by the bedside, and the person starting to stir was a false. So there's all those things that can, as we put it into practice, it kept getting better, and it will continue to get better. But the beauty is it by itself doesn't stop somebody from falling, right? The person, if nobody was around, there's a tree falling, do you hear it in the forest? If a person gets up and no one's there to greet them as they're getting up, they'll fall. So what it is, and I think is we should continue to make this distinction, because we can do the same thing in sepsis, where we can maybe pick up their heart rate and their respiratory rate going up a little bit of a variance, but enough to say, okay, their core body temperature, even though you don't register it, is beginning to increase, and this patient's now developing early sepsis. But it shouldn't then say, okay, now we're going to automatically give this patient medication, because that's taking the decision-making process and the physician nurse end of it out of it, which is not something that you should do. But what it can do is now give actionable information to somebody that can do something long before they could have known about it in the past.
So it sounds like, with just sticking with fall prevention for now, it sounds like that's working in the hospital setting, but we also know that this is a serious problem in the home. And so how do you, or can you apply this technology in the home so that, when mom is trying to get out of bed and she shouldn't, that someone is alerted? Yeah.
So let's do one thing first. How do we identify those that are at risk, and how can we help them if they're at risk today, either through physical therapy, exercises, or alerting the family that they're at risk and we got to change things around in their house? We do a very bad job of that in the past as physicians, and it's a $50 billion problem for Medicare from an economic standpoint. So we took this same technology and we put it in a doctor's office, and within 10 seconds, it can watch the patient walk, less than 10 seconds, actually, same kind of LiDAR technology and artificial intelligence, and say, okay, because of the patient's gait speed, because of the patient's weaknesses and whatever, they are either at a high risk, medium risk, moderate risk, or low risk for falls. And here, if they're at a high risk, this is what we can do from a physical therapy standpoint, exercise, in order to make them better. We did that for Medicare, actually, and we decreased falls at home by 70%. That's a significant impact without putting anything in their home, okay? So you didn't need anything different other than just identify that someone is at risk, and then give them a plan as to how they can be better. But you can use the same technology in a home. Actually, what it can do, and we've begun researching this, is you can actually tell if someone's taking their medication, because it can learn the motions that one does in order to get out the glass of water, get the pill out, put the pill in their mouth, swallow the glass of water. And now with the same technology, you can tell whether someone is being compliant, maybe forgets, whatever, and send alerts, which is even, in my opinion, is probably more important than deciding whether or not they're making something for congestive heart failure or whatever, because more people are non-compliant, which causes more problems than anything else. That, and do you have your doctor's appointment? That's what causes all the readmissions today.
Yeah. So what about predicting a heart attack? What about uh, sepsis, as you mentioned?
Yeah.
Is that the credit card size thing that you were talking about?
Yeah. So we are now in partnership with a company who makes a credit card sized device that you can wear on your arm, and it has a battery life of 17 days. You can actually leave your house, come back to your house. It downloads all the data, and it measures your blood pressure, your respiratory rate, your pulse, your temperature, your oxygen saturation. It gives a 3-lead EKG, all within wirelessly done. Downloads into the AI software, and then can monitor patients. Say someone's discharged from the hospital, you have them on this monitor. You can tell whether they've developed a bladder infection. You can tell whether they've developed any kind of infection, for that matter. So you start to now take this continuous monitoring and artificial intelligence into the home unobtrusively, and so they don't have to be tethered to either a bed or a chair or even their room, for that matter, and give physicians, nurses, and caregivers the types of alerts and information that they can actually make an impact.
So is it communicating to a device? Like, is there an app that goes along with this that has to be, and you have to give them, if they don't have a smartphone, you give them an iPad or something? Is that how it transmits the information?
Yeah, so the process itself is, first you have the data collector. That's the thing you wear on that's the sensor. So that's gathering data. Then you have to drop that data and get it somewhere. You can use QNX, which is a Qualcomm piece, which uses Kindle technology. So remember the old Kindle, probably nobody does because we always have our apps on our phone now, but the old Kindle, you didn't have to have an internet connection. It just sent a low grade signal to a satellite, and it didn't cost anybody anything. Our system works on KBs. It does not work on megabytes or gigabytes. We can do it on a phone. Believe it or not, we can send all that data on the phone. Now, video and things like that obviously take more, but data collection and transmission can happen on the lowest wavelength. Or it is actually cost effective to give the patient an iPad so that you both can communicate with them, which gets to the last point I should make that I learned in virtual. But you can communicate with the patient and also download that data. When you think that 5% of the people spend 50% of the dollars, it's pretty cheap to give them an iPad, because one of the things we did at virtual was we did that with those at-risk people. And we learned that the increased access to care, as well as the data that we receive, and we decreased their cost by 60%. The
Wow.
impact on economics is astounding. In a hospital system that has $1 billion in revenue, and if they were only going on a Medicare Advantage at-risk contract, they would have revenues of $30 million for every $1 billion new revenue, new bottom line revenue. $30 million saved for every $1 billion in revenue that they have. So you take Mercy, it has $7 billion in revenue. That's $140 million drops to the bottom line. Just on one contract, you throw in ACOs and your own employees and so on and so forth, you get up to $90 million for every $1 billion that you have.
So we talked a little bit about this on our previous conversation. Talk a little bit about the economics of healthcare. And what I mean by that is, we're in this, what's the analogy that people always use? One foot in the canoe, one foot on the shore,
Yes.
With value-based care. I see the same kind of thing with some of these devices. It's like you can make the cost-effective argument. You can make the argument you just made here, $30 million for every $1 billion in revenue. But my sense is, and you can tell me your real world stories. My sense is that the average CFO that's living in a fee-for-service world doesn't have, let's say the less strategic CFOs that are out there, has a shorter time frame, and all they're looking at is the price tag. They're not thinking of the potential savings or potential revenue generation elsewhere. Am I right about that, or am I wrong?
No, you're definitely right. And it's actually even worse than that. First off, let me caveat this, say this is not a value judgment on people in general. People in healthcare are wonderful people, and they mean to do extremely well. However, we build an economic model around people that now prevents them from doing the right thing many times. So it's not only that, gee, I don't want to make the investment, but that's going to decrease my bed days, which is going to decrease my revenue. So not only do I not want to make the investment, which because it won't necessarily, I can't see how that's going to drive revenue for me, but it's actually going to decrease my revenue if it works the way you say it does, which is true, because it does decrease fee-for-service revenue because you do decrease utilization. But you decrease utilization because patients stay at home. You decrease utilization because patients are intervened in early in their disease condition. All good things for patients. So we have to find a way to transition. And it has to be a transition, by the way. It can't be, we build an infrastructure around healthcare that you can't take it apart today. So now how can we maintain the support of that infrastructure while we transition in the economic model? There actually is a good transition model if people take the time to look at it, but they also have to believe that value payments actually generate revenue. I'll give you a story. There was a medical group, won't even tell you where the area was, but the doctor who was very well liked and supported came to them one day and said, we're going to take risk. We're going to take our Medicare Advantage patients and we're going to take risk. Who wants to take a risk? And he said, raise your hand. Nobody raised their hand. He said, okay, here's what I'm going to do. We got 9,000 Medicare Advantage patients. I'm going to take all the risk. I'm going to build an infrastructure around that to take the risk. And next year, I'm going to come back and say, here's how much we made or how much I made because I took all the risk. He comes back next year and says, okay, guys, it was a good year last year. You all did well. You got paid the way you were supposed to get paid. I made $12 million last year. And I put that in my bank account. Who wants to take a risk? Believe it or not, at that point in time, only 20% of the physicians raised their hand. This is what we're dealing with. You have even when the economics become evident, the change is slow. It took 4 or 5 years to get everybody involved, and they continue to make extremely high profits in the risk business, and their patients benefit from that. But change is difficult for healthcare. And the best meaning people, such as in Congress, when we came through with Obamacare to give everybody an opportunity at health to have health care, that was an insurance model. That was a support economically those who couldn't afford it. The problem is it didn't change the delivery model. And so there wasn't enough places for people to go, and it became much more expensive because of the delivery model that was present when this came about. And so now we're arguing about Obamacare. Instead, we should be arguing about, yes, everybody should get health care. Let's change the delivery model so we can all afford that.
So this question has come up, what we're talking about now, in several podcasts that I've done on healthcare rounds. And the question that I always come back to, does that mean that the only successful health systems are going to be the ones where they've got an insurance product, so they have to manage risk, i.e., I'm thinking of Kaiser, Geisinger, Intermountain, where they've got substantial numbers of people that they're covering so that they're seeing the whole spectrum, right? If you don't have that, or even if you don't have a Medicare Advantage product, maybe you're a lot more, what's the right word, myopic in your decision making. Whereas when you have the fully integrated system with the insurance, with the payer arm, it seems like to me that may be the only way to solve the problem that you're addressing. I could be wrong. There are other ways, yes, but I'd like to hear your thoughts.
Yeah, so I challenge that because that says that in order to be successful, you have to be able to control all sides of you have to be in control of all sides of both the economics and the delivery and the patient procurement. And that's not true. At least I don't believe it's true. I think what you have to do first is say, we're going to do what's best for the patient, and we're going to be patient-centric about what we do. And that not only entails that you put things in place to keep the patient well and healthy, but also you put access there so that they can reach doctors when they need to reach doctors, when they not a week from now or 6 months from now.
Right.
You start to change your infrastructure from that standpoint. A, your fee-for-service business will improve markedly because everybody will love you. And so they'll want to come to you. So that increases your revenue. B, you build a primary care organization, either with nurse practitioners and physicians, and teams, and you use virtual, like we're doing now because of the pandemic, telemedicine, and you increase the ability to have access to the primary care organization. And once you do that, you increase your volume because people will love you. And if you increase your volume, it floats all boats. So you don't have to own the delivery model. You have to get the data, from the insurance model, but you have to get the data from the insurance model so that you can continue to learn and get better. But you do have to change your delivery methodology and your delivery values. So instead of saying, okay, we're going to get more cardiologists and more MRIs and more neurosurgeons because that's what drives revenue. It does in a fee-for-service world, sometimes less so than it used to, but that's myopic. What you want to say is I'll give you an example. One of my favorite movies of all time was Moneyball. And in Moneyball, Peter Brent went to Billy Beane and said, owners got it all wrong. They think they're buying players and people hit home runs, and that's what is going to make them successful. What they really want to do is they want to buy wins. The more we win, the more successful we are. And in order to win, you have to have runs. In order to have runs, you have to have runners. And that's what evolved into all the new baseballs it is today. In healthcare, you don't need to have high-priced specialists like the home run hitters. You don't need to have all the equipment in the world. What you need to do is have patients. And how do you get patients? You get patients through access. And how do you create access? You get a strong primary care and a strong workflow and strong processes that do that. And then you do a good job taking care of those patients. Those will be the systems that are successful, not because they own everything necessarily, but because their whole delivery model has changed to be patient-centric.
So is that why Mercy is successful? I haven't looked at their balance sheet lately, but I think that most people would agree in the industry and in our industry that they've done a lot of things right over the years. How would you assess where they are in terms of that patient, putting the patient first? And then really what I'm getting at is, if they're not a customer now, how would you take this technology and go to Mercy and say, my old employer, this is something that you need, and here's why?
Sure. Yeah. So first off, Mercy struggles like every other health system struggles, particularly not-for-profits, because decisions are made by committee and decisions are made slowly. So they have not been able to they are successful. They have not been able to make the full transition yet, and hopefully they will. I think Kaiser's a better example of success in making the transition. We are at Mercy at the present time, and we're doing a 3-month pilot for them at our cost. And we put the fall prevention in beds on a neuro floor. And in 3 months, what was normally about 20 falls or so a month, we have had 2. And those 2 were because, one, they didn't turn the machine on. I don't think that's the technology or AI problem. And B is they were unable to get there in 60 seconds. So maybe there was 1 fall in 3 months. We think if once, as the nurses begin to trust this type of technology, you get this falls down to 0. Unless you have a real agitated patient that needs a sitter to be there because they're jumping out of bed every 5 minutes. So we think that we'll put the technology in. If there's someone out there that's interested, we'll put it in for free so that you can try it, see how it works, because we're very convinced and we have the results to show it, that we know we can decrease your falls. We think we can decrease it down to 0, but we know we can decrease it significantly.
And what does that look like if you had to estimate dollar-wise? What does that mean?
Yeah.
What does that mean for them to, 240 falls a year go down to 0 or to 5? What does that mean for them economically?
So we calculate the ROI based on just data that's out there generically. And it's about a 30-to-1 payback. You got to understand that the machine that we put in and the technology we put in costs less than 30 cents an hour. So it's if you compare that to sitting, you compare that to virtual sitting, you compare that to all other technology, it's significantly cheaper, and it gives back that 30-to-1 payback. And secondly, because of what I've learned through virtual, we've put other things in it. It can you can virtualize a room. You can have a video visit. You can, if you get an alert on the phone, you can actually hit an app on the phone, and it shows you the patient. You can see the patient. You can talk to the patient. You can do consults. So it basically virtualizes the room. It connects with that card that I talked about, that vital sign card. So you can actually monitor patients 24/7 with ICU technology being untethered, and it goes through that. So that's what we're creating, is an ecosystem that allows the use of artificial intelligence across the acute setting, the post-acute setting, and the home, to be able to gather data from the patient through technology, use that data to have actionable have actionable alerts, and also form the relationship through the whole telemedicine virtual visit piece.
Tom, this has been fascinating. I got to ask you though, last question is, what's next?
Yeah.
What's next for VirtuSense, and what you see on the horizon for AI?
Yeah, so two things. One is we're moving into the home, as we talked about, particularly on the at-risk patients, but later it'll be like having a security system. It'll be your health security system, so to speak. But as far as AI is concerned, I think that AI is extremely important, but it also has to be given respect. And what I mean by that is, AI is not a replacement for physicians. It's not a replacement for nurses. It's not a replacement for not only the art of medicine, but that decision-making process. But what it is that it's the ability to use sensors to collect information to give you actionable data, and then the decisions can be made. And it can be that, and it can allow for that communication to provide people access when they physically can't be there. So it decreases and destroys those geographic limitations.
So we're not going to find ourselves in some Terminator situation.
We both laugh, and I think, but honestly, that I can't predict, because I've seen human beings screw up almost everything at least some point in time. So it is our responsibilities as leaders, yourself and myself and others as physicians, to make sure this is for patient care, not necessarily to drive revenue, not necessarily to make people wealthy and lazy by not thinking. And we have to be constantly vigilant that it doesn't take over.
There's an ethical responsibility there, in other words.
Very well said.
This AI stuff is really, it's amazing. And I can see all you have to do. It's like one of those things, when we show somebody our work, they say, sign me up. And we do really good work. I will say that. But it's one of those things where you're doing what you're doing at Mercy, you're going to be successful no matter where you go, because you're going to be able to demonstrate, right, that the ROI, 30-to-1 ROI, and the better patient care. And we all know why we don't want people to fall, because a lot of times that's the last thing that happens before this sequence of events and they die. So, yeah, it's cool stuff.
It is really cool stuff. And to your point, and I know your profession and company does this same thing, and that's, it makes things better. And it gives people intelligence that they can then act better and make impact better. So we're very much on the same par.
Yeah. I hadn't thought of it that way. So, well, Tom, this has been great. Maybe we'll come back in a year or so and see how things have progressed. The technology is fascinating. I'm excited for you that you're able to retire and come back and do something fun and innovative. So hats off to you for that as well.
And I appreciate that. It's truly been a blast, and it is a lot of fun. And hopefully it'll keep me young and not stale.
Great. Well, stay in touch.
All right, you bet, John. Thanks.
Thanks again.
From all of us at Darwin Research Group, thanks for listening. Healthcare Rounds is produced and engineered by me, Kim Ishudo. Theme music by John Marchica. Darwin Research Group provides advanced market intelligence and in-depth customer insights to healthcare executives. Our strategic focus is on healthcare delivery systems and the global shift toward value-based care. Find us at darwinresearch.com. See you next round.